Welcome to the recorded version of the Grantmakers and Aging web seminar, Aging and Homelessness, featuring Peggy Bailey, Director of Health Systems Integration at the Corporation for Supportive Housing, Nancy Sasaki, Executive Director of Alliance Healthcare Foundation, Amy Kleine, Program Director, Basic Human Needs and Health at the Harry and Jeanette Weinberg Foundation, Michael Marcus, Program Director, Older Adults at the Harry and Jeanette Weinberg Foundation, and John Feather, CEO of Grantmakers and Aging, from May 20th, 2015. This event was made possible by a partnership between Grantmakers and Aging and the John A. Hartford Foundation. Technical and production support is provided by the American Society on Aging.
Thanks very much, Steve, and welcome to all of our listeners today. We have a large group with us today, and we're very pleased about that. And welcome to this conversation with GIA. As Steve said, I'm the CEO of Grantmakers and Aging, and we're delighted that so many of you have taken time from your busy schedules to be with us on this important topic. Before we begin, I want to thank the John A. Hartford Foundation of New York, whose support is making today's webinar available free of charge to our audience. We also want to thank funders Together to End Homelessness, the Alliance Healthcare Foundation, and the Harry and Jeanette Weinberg Foundation for their support of today's presentation. I also want to thank the expert team at the American Society on Aging for providing technical and production support for the series. Homelessness among older adults is on the rise and predicted to accelerate as more and more seniors find themselves with shrinking Social Security benefits, decreasing options for affordable housing, and managing multiple chronic diseases on a fixed income. While the profile of an elderly homeless person may represent one of two scenarios, either a person who has been homeless as a younger person or a recently homeless senior, the needs and the solutions are the same. What are some of the root causes of homelessness among older adults? And what are some of the promising interventions that are being employed in our communities? How can we build resources within our neighborhoods and strengthen our services to address this growing problem? Our speakers today have been deeply engaged in this growing issue of homelessness among older adults and the interventions to address that issue. We're very pleased to have Peggy Bailey, the Director of Health Systems Integration at the Corporation for Supportive Housing, Nancy Sasaki, the Executive Director of the Alliance Healthcare Foundation, Michael Marcus, Program Director for Older Adult Services, and Amy Kleine, the Program Director for Basic Human Needs and Health, both at the Harry and Jeanette Weinberg Foundation. We welcome all of you. Peggy, let's start with you. Could you tell us something about the underlying issues and the facts that we know about older adults and homelessness? What are some of the proven interventions, both nationally and locally? And tell us about your organization and some of the work that you do in this area.
Great. Thanks, John. I am very happy to be here as a part of this webinar presentation. This is a topic that is increasingly becoming more and more important as we see an increase in the aging population that's homeless. Next slide. So today, as John mentioned, I'm going to go over what we know about the key populations that CSH is looking at in this area, what the services needs are, supportive housing as the intervention that can help, and some of the projects we have underway here at CSH. Next slide. Next slide, sorry. So what we know about the elderly homeless population is that, so there are three populations that we're going to be, at CSH that we care, that we think fit in the bucket of the aging homeless population. First is the elderly who are homeless, so those over 62 who are experiencing homelessness. And what we've seen in the recent annual homeless assessment reports to Congress, which you'll also sometimes hear referred to as the AHAR, the acronym, which HUD reports to Congress on every odd-numbered year. So the most recent data we have right now is from 2013. And you can see that from 2007, 41% of the homeless population was over 62, and now we're at 5.4% of the homeless population is over 62. Next slide. to put that into some projected forecasts, Tom Byrne, who's now with Boston University and has been doing work in this area, shows that starting from 2010, it was estimated that we were spending about $1.45 billion on healthcare services for this aging population. And by 2025, if nothing changes, that will have increased to $2.4 billion. And as we all know, that's not sustainable. Next slide. The next population that some other characteristics of the senior homeless population are included in this slide. So, and we use Chicago as an example. We've been doing work in this area in Chicago in depth. So in Chicago, there were about 236 people experiencing homelessness who were over 62. We can see that 41% of that population had been homeless for more than 1 year. 52% had a disability. 10% were homeless and housed again 3 times in a prior year. So they were housed. That didn't work for whatever reason. They experienced homelessness and got housed again, which, as you can imagine, is quite unstable for those folks. And then 29% were chronically homeless. So this just provides a snapshot of one city and what the senior homeless population looks like. Next slide. The next population that we're looking at CSH is those who need to age in place. So supportive housing, it has been around for over 20, almost 30 years. So there are people that have been in supportive housing for that length of time, and are aging in their units, and that unit may have come with some case management in the beginning. Now that person is stabilized and the case manager has moved away. But now as the person ages, you have coupled maybe some underlying mental health or substance use or the side effects of substance use now as they age, along with the normal chronic conditions that can develop as someone ages. So how do we as supportive housing fill that role of helping someone stay in their house for as long as possible when we're not necessarily set up to be a full-fledged assisted living center, or people don't have that same kind of access as maybe higher level income folks have to assisted living? So we can see that in Chicago, for example, reported that 50% of supportive housing tenants were older adults. And as I said before, homeless reports are showing that very high levels of people living in supportive housing are aging. And we did our own industry report that showed that 39% of our supportive housing providers are running programs that are specifically designed for frail, elderly, homeless individuals. Next slide. Finally, the third population that we're looking at CSH is a cohort that is over 50 but experiencing the conditions of someone much older, maybe in their 70s. So especially as we're doing more to target the most vulnerable, highest cost users of the healthcare system, those people are usually older, but they have significant illnesses that traditional supportive housing even isn't prepared to address. That's been a fascinating part of our work in this area. Actually, we've been having providers who are very experienced in supportive housing target their services to the most vulnerable, highest cost users in the community, and they're coming back and saying, "Whoa, wow, we didn't know that we thought we were serving the hardest to serve, and now we're really serving the hardest to serve." And how do we do that for this younger population that may not have the supports in place to that older adults could have access to? And how do we help our supportive housing providers develop new partnerships in this area? So this slide just goes over some of the things that we're seeing about rates of chronic illness, and I'll get into that a little bit later. Next slide. So when we talk about chronic health conditions, what do we mean? What are some of the geriatric conditions that we're seeing in this population? So many fall in with cognitive decline, whether it's just general memory loss, or more significant challenges like Alzheimer's or dementia. People experience falls, so this comes into play in the design of the building. How do we make sure that people, that we can prevent falls, or if people do fall and have challenges getting back up, that they can access help as quickly as possible. And then vision and hearing impairment that comes along with aging. On top of that, for this homeless population, there are also underlying behavioral health needs, whether it's mental illness that now is complicated by the new ailments that the person is experiencing, or the long-term side effects of substance use. It could be that someone did reach sobriety, but because of sustained substance use earlier in life, now they're having more significant challenges. Next slide. And again, this slide goes over work that we've done in Chicago around rates of illness. So you can see of those 236 people that I described before, 50% had gone to the ER at least once in the past 3 months, but 62 individuals of the 118 that you can see on the chart went to the emergency room more than twice. 42% were hospitalized in the past year, and 44 of those folks were hospitalized more than twice, and 50% had overall chronic illnesses, which and as you can see, people also had drug and alcohol challenges and mental health issues that they are living with. Next slide. So along with these, so as you can see, the conditions that people have, now what does that mean? What does that mean that we have to do in supportive housing in a more intense way than we've had to do in the past? Things like home health care and visiting nurses, occupational therapy, medication management. In the past, for example, so medication management is a great example. In the past, when we talked about medication management, we were thinking more about things to help someone with their substance use needs and being able to detox. Now, when we talk about medication management, we're really talking about regular medication management, helping people remember to take their blood pressure medicine, remember to take their heart medicine, things, and having that handy and knowing, helping communicate to the doctor what medications folks are on is vitally important and a new activity for us in supportive housing to that degree. Next slide. Other services include nutrition and meal preparation, helping people overcome hoarding issues, and what is called in the home and community-based services side of the world, activities of daily living, being able to shower, get dressed, comb your hair, cook, those sorts of things that we, in supportive housing, we may have needed to help people with as they initially transitioned into housing, but in this context, with the aging population, we have to help them with on a daily basis. And then one of the most important things is end-of-life care and being able to help, in some cases, fill the role of family that would be able to help someone as they with end-of-life care and be able to prepare themselves and any relatives that they have for that inevitability. Next slide. So what we know is that supportive housing does work. We just are going to have to, as I say, up our game in this respect. We're going to have to intensify our services and make new partnerships with experts in the community that maybe we haven't connected with in the past. So that includes maybe the area agencies on aging might not have had a history of partnering with supportive housing, but that's something that we need to do. Linking better with medical respite so that people, as people move out of the hospital back into home, it's not a linear projection that once someone gets home, they're never going to have to go back to the hospital. And then that middle ground that, some of us may go to a recovery care center before we're able to go back home. But for folks without insurance or for low-income people, that might not be an option, and medical respite plays that role of helping people move back into housing. But we need to be able to make sure that we can hold on to that unit for the person while they're going from the hospital in medical respite and eventually coming back home, or using mobile medical respite to help people in their home. And as I said before, the new skills with end-of-life care, I can't mention that enough. What we hear from case managers in particular, that can be a hard piece for frontline staff to be able to handle, not only for the client but for themselves, because they care about the people that they're serving, and in serving an aging population, you have to be able to deal with that loss. Next slide. So I'm going to end with just a few projects that we're working on at CSH. One, we're a part of the National Leadership Initiative, which is a partnership between us, Leading Age, Hearth Inc. in Boston, which I think you'll hear about more later, and Shelter Partnership in LA. We've hosted 2 convenings. The first one was in 2011 and produced the policy paper that I have the web address for here. The second one was in Los Angeles and focused more on implementation and design and actually making projects come to fruition. We're hopeful to be able to do a next convening possibly late this year, but more likely early next year. And specific work in New York, our New York work, we've been facilitating peer-to-peer collaboratives around that are looking at housing, helping the providers identify and problem solve their issues, and sharing resources, and developing a couple of tools, one that's linked here, an overall best practices for supportive housing for aging tenants, a toolkit that we'll be developing later this year, and hosting a convening, an aging forum that's looking at both design and services access, and lending specifically to supportive housing projects that are targeting this population. In Connecticut, we are about to publish, you should see within the next couple of weeks, a tool that we're working on with the state that looks at state-specific to Connecticut issues in this population. It helps agencies identify their competencies and any gaps. It has a statewide resource list for accessing services, covers the state agencies of jurisdiction, has suggested staff training framework so that you can to line out what things your staff needs to be trained on to serve the population. And it has a checklist for end-of-life care and all the steps that need to be taken to make sure that someone has dignity in their last days. And if you want to learn more about some project profiles we have, you can visit our website. And I will pass it back to John.
Well, thanks so much, Peggy. That was extremely helpful and provides the groundwork for us here. Before we move on to our next speaker, I want to remind our audience that we will be having questions to our speakers at the end of our presentations. You can write in your questions at any time under the question box that you see on the right-hand part of your screen. Just open up the question section and start typing away. I'll be asking those a little bit later. So at this point, Nancy, let's turn to you and hear about an innovative new initiative that your organization's been involved with around this issue.
Thank you, John, and thanks to Grantmakers and Aging for putting this together and presenting all of this information. We're really excited to be a part of it. At Alliance Healthcare Foundation, we provide funding for just San Diego and Imperial counties, which are the 2 southernmost counties in California. I also serve as the chair of our Funders Together to End Homelessness San Diego chapter, and I've always looked at this intersection of seniors and homelessness. This particular, I probably want to go to the next slide. I'm going to talk a little bit through our innovation initiative. We provided funding for a project called the Community Information Exchange, to which I will refer to as the CIE, and it's really creating these networks for enhanced care coordination. I think that if Scott Beckler-Levin were able to be on this call, he would be able to provide you with a lot of information, but maybe since I don't know as much, we'll go a little quicker. Next slide, please. I think what you'll see, when you heard Peggy talking about this care coordination and the coordination of all of these other agencies and everything, that's really where this project came about, was from the medical side, knowing that providers are seeing people in their offices, in their hospitals, in different settings where they don't actually get the whole picture. They might see their own medical record, They might be part of a health information exchange in the community where the hospitals and potentially some of the community clinics are sharing information, but rarely do they have a connection to the social service information that's also might be happening to the particular client that or patient that's sitting in front of them. So the CIE is a way that we provide the seamless care coordination that can improve people's health outcomes by allowing people to see what else has been going on in each of the people's lives, whether it's through our HIE, the circle on the left-hand side, through our HMIS system, our Homeless Management Information System, our 211 here in San Diego, what the County Health and Human Services Agency is putting together, the social service providers, the federal funders, as well as fire and EMS. Next slide, please. This slide shows you a kind of a process that can happen to the homeless people in the downtown area of San Diego, which was the first cohort that we worked with. If there's a client that's drunk in public, the ambulance arrives, they're transported to the emergency department, the hospital does what they need to do many times and then end up discharging them, not knowing exactly sure who to notify. They end up being there until they detox, and then they're sent away. They end up getting called back. With the implementation of the CIE, what can happen now is that actually before the ambulance arrives, they can look up this particular client and find out who the case manager is in the homeless sector that might be able to manage this person before they take them to the emergency department. If, however, they make it to the emergency department, the hospital discharge manager can look up that person in the CIE, determine who the case manager is, and notify them that this person is about to be released, so the case manager can actually take action on that client before they're released to the street or to another provider that maybe would have to start all over. So it's a way of coordinating all of that information so that there is effective and smooth handoffs for that particular person. Next slide, please. The first cohort worked with two of the homeless service providers, Father Joe's Villages and PATH, which is Connections Housing, and both are in downtown San Diego. They provide housing. Father Joe's has a clinic. They both provide wraparound services. PATH is also developing a workforce development piece. We also are connected with the San Diego Fire Rescue, so the EMS department, as well as the two hospital systems that serve the downtown area, where many of the homeless, when they're picked up to be transported, are taken. So now they can actually view information between these organizations. There are also some possible expansions you'll see down below that I'll talk a little bit more about in just a minute. Next slide, please. The Downtown Homeless Arena, the 5 organizations that I talked about, came online at various points in time starting in July of last year. At this point, and actually this was as of the first part of this month, there were almost 2,500 of the downtown homeless population entered into the CIE system, which represents about 72% of the homeless population that we've identified in the downtown area. So there's an opportunity to see that many clients at any one given time. Next slide, please. What happens when a provider goes online and tries to look up information, they'll always see at least theirs. What this particular pie chart shows is that they also will see potentially information from at least one other. So like St. Vincent de Paul will see also the EMS system, what happened with that particular client, how many times they were picked up. They can also see whether or not that person also tried to access services at PATH, the other service provider in the downtown area. And many times they can actually see information from all 3 sources. Next slide, please. In fact, some of the feedback that we've gotten from the providers was that they were able to get a broader overview of the client, including some of their apparent mental health information that the client was denying. So the client's not divulging everything honestly or completely, and they're able to look that up and see more information. It's actually imperative information, they say, to save time and develop a more accurate case plan because they can see where else has this person been, what other services or programs have they accessed, which ones did they fail out of, which ones have they been partially successful. And they also did report that they had gotten a hit almost every time that they logged on. So that's also exciting for us to know. Next slide, please. in the ability to look up this information, we also are learning other ways. We did decide that funding this organization was really about learning as we develop and as we go. So we are learning things beyond what we thought we might be able to see in this system. For example, Father Joe's discovered that they were the third most popular site in the downtown area for EMS to pick up to deliver to the emergency department, and yet they had all these protocols in place to try and reduce that. So they were actually able to look up through the CIE system all of the times that they were using the emergency department, the EMS system, and to redefine their protocol so that they have further reduced the number of calls that they're making to the EMS system. And of course, underlying all of that is decreasing the cost. The other thing that we discovered was that at one of the hospitals, when they provide services to a homeless person, typically they don't have any of their documentation. So the hospital was actually going through and doing all of the expenses to get the documentation in order to bill or to be able to get reimbursed for the services of that person. So they had over 650 different documents for homeless people, like their driver's license or their birth certificates or a Social Security card. And then they were able to look up who the case manager was through the CIE system and get these documents back to the clients. And where at the same time we had another project that was about to expend a lot of money to try and get these documents for the homeless, and they were able to match up these and reduce the cost of getting that information for the people they were trying to serve. Next slide, please. Since we've been in the process of this particular project, we have two evaluations that are going on. We were able to do one that's a very small one because we really wanted to see if we were having an impact. And so they were able to look at only 22 clients, and this is a very small number, so it's not transferable or we can't talk about it in the general sense. They looked at 22 clients who were enrolled in services prior to the CIE and stayed in those services after the CIE was implemented. And out of 10 clients, they reduced the number of ambulance trips by 47 in that short period of time. There were 4 clients where their trips actually increased, and so we're able to look into that and see what were the circumstances that the number of trips they made actually increased, because what we want to do is see more of that green where we're actually reducing the number of trips. But there were a total of 36 fewer EMS trips in that 4-month period of time that we were comparing. Next slide. So now that we've implemented cohort 1 and we're looking at doing some expansion in that area, we started looking at what the second cohort would be. And cohorts are groups of people that we think we might be able to work with the organizations that are serving them. And what we decided to do was move into, I keep saying we because I'm so attached to this project, but the CIE determined that the next community to go into was going to be the aging in community. So this is where we were really able to see the intersection between homelessness and senior services. And where this started out was to look at this in terms of what the services were happening to keep seniors in their homes. So providing the meals, providing the concierge services through elder help, making sure that they had people that were coming and mowing the lawns, taking them to groceries, to get groceries, or those kinds of things. And the example here is that if somebody were to fall at home, the ambulance arrives, they take them to the ED, this kind of whole system that I was notifying before, and everything happens and then they go back home. But in the meantime, what happens many times is Meals on Wheels goes to deliver a meal. The person doesn't answer the door. That triggers their emergency response cycle, which means that they're going to call EMS and they're going to call the sheriff's department so that they can get in to the house or determine whether or not that person's in there. And then they realize that the person's not there and they don't know what's happened. So now through the CIE, they're going to be able to look up that person was, in fact, transported to the hospital. In fact, they'll probably get a notification that the person was transferred to the hospital, and they won't even show up on the doorstep. And so then they won't trigger the emergency response system. And then when the hospital is going to release that person, they can notify Meals on Wheels, they can notify elder help, they can notify other systems saying this person's returning back home, please start their meals back up, please start checking in on them again. And then we've better surrounded that senior with the services that they need, and we haven't triggered excess costs that we don't need to expend. This particular cohort is scheduled to come online go live in July, and so we're doing a lot of that background work that we need to do to ensure that all of the IT systems are ready to communicate that data. I did forget to mention that the HMIS system, the Homeless Management Information System, that collects all of the data from the providers in our community, in fact, represents 70 of the providers in our community with HUD funding, is moving towards a real-time data exchange, so we know exactly when beds are available, we know exactly which people are in which services, and that kind of thing. So we're very excited about that. The players in the next slide, please. The players in the downtown aging community, there are definitely some overlaps between the two hospitals and the emergency system. We are also, as you can see, bringing on the senior services, so serving seniors, Meals on Wheels, and Elder Help, which are on the top line, and St. Paul's, which is the middle and the second line, are all coming on board when they go live in July. Serving seniors in St. Paul's are the ones that have the housing, day centers, medical services. They have independent living, they have skilled nursing, they have assisted living facilities. Meals on Wheels, I think people are very familiar with what they do in terms of providing meals and check-in services to make sure that the seniors are able to age in place, as well as Elder Help doing a lot of these wraparound services that they need to be able to stay in their homes safely and efficiently. So they're all coming on board in July. And if you go to the next slide, this really begins to show you where the synergy is between the two cohorts. There's the ones on top that have the aging focus, the ones on the bottom that have the homeless focus, and yet in the middle is where you see there's aging and homelessness that are really coming together. And you'll see that even though there's more of a focus on one end or the other, there's still that overlap between their, whether they're aging seniors and whether they're focused on homelessness. So we're really looking at now, once the second cohort gets on board, to begin to understand all of the savings and the care coordination that's happening in this particular arena. We're looking at how we can scale and expand this beyond these two cohorts, and especially to get in more of the people that are in need of these kinds of coordination of care throughout our region. We're working on a regional vision with the other databases that are collecting this data between the Health Information Exchange, through our county and the systems that they are developing, through our 211 system, as well as our Community Information Exchange, or the CIE. And so it's really exciting. It's really fun to see kind of how this is helping these organizations not only see what they're doing, but see what they're doing in coordination with the other providers, so that they have we're hoping to get to almost a 360 view of all of the places that providers are touching a particular person in our community, so that we can have better care coordination and reduce costs, increase the quality of the care that's being provided, and to increase capacity for our providers. So thank you very much.
Well, thanks, Nancy. That's a very inspiring example of drawing a whole variety of programs together to meet the needs of these individuals. Before we go on to our next speaker, I want to remind you once again that we will be having questions and answers following this next part. You can write your questions in. A number of you already started doing so. Under the question box that's on the right hand of your screen, just open that section and drop down. So Amy and Michael, you're both with the Harry and Jeanette Weinberg Foundation. And tell us a little bit about how you got involved in this particular area, and how and the kinds of programs that you're looking at, and particularly how other funders can be involved in this kind of work.
Thanks, John. Before we do that, I want to thank GIA for putting this together, and funders together, and for this great collaboration, and to ASA for producing this, providing technical support. Peggy and Nancy, it was great to hear about the work that you're doing in Chicago, a place that's near and dear to my heart, and San Diego, and a shout out to Elder Help, which is one of our favorite grantees. Of course, they're all our favorite grantees. Let me tell you for a minute about, we have to change the slide, please. Let me tell you for a minute about the Harry and Jeanette Weinberg Foundation. Our mission is to help low-income and vulnerable individuals and families by providing grants to nonprofits that provide direct service. Next slide, please. overall, the mission of the older adults portion of the Harry Jeanette Weinberg Foundation is in this quote from the great Rabbi Abraham Joshua Heschel. The test of a people is how it behaves towards the old. It is easy to love children. Even tyrants and dictators make a point of being fond of children, but the affection and care for the old, the incurable, the helpless, are the true gold mines of a culture. The Weinberg Foundation makes about $100 million a year in grants. About $38 million of that go to the older adults grant-making area. It's the largest grant-making area of the foundation, and we believe we're one of, if not the largest grant-making organizations, one of the largest older adult grant-making organizations in the country.
And this is Amy Kleine. We are co-presenting because we want to make a point of how we collaborate within the foundation. We do organize by different program areas, and we do tend to get wrapped up in our own program areas. I oversee basic human needs and health, which is more locally focused on Maryland and is essentially homelessness, hunger, and health. But of the approximately $10 million in grants made each year in this portfolio, about 70% last year were homelessness and housing. So there is a predominance of focus on that issue.
So next slide. So the foundation makes many grants a year, and in a little bit we'll talk about how homelessness and aging come together in general. But here's an example of 4 grants that we've made in recent years to organizations that are working with folks who are homeless and older. Hearth, of course, I think this is still true, is the only organization in the country which is dedicated specifically to serving older homeless individuals. DeRoe is an organization serving older adults in Manhattan. For the most part, they have a homeless prevention program along with its friendly visiting program, as well as a transitional house for folks who are making a transition from the streets to permanent housing. And most of the folks living in that house are older adults. The Downtown Women's Center in Los Angeles is permanent supportive housing, obviously for low-income older women who have mental health issues or people with disabilities. And finally, Common Ground, which is a well-known provider of services to homeless folks in New York City, and have a building in Brooklyn which is specifically focused on older adults. Next slide, please.
So we want to talk a little bit about how this is playing out locally for us here in Baltimore City. We have the opportunity each summer to bring on a graduate intern, and a few summers ago we asked that intern to focus very specifically on this issue of older adult homelessness locally to see what she could learn and whether we can bring a group together to discuss it. So we have here some local findings based on data available at that time that basically show the homeless older adult population was increasing. And you can see we broke it up from 51 to 61-year-olds and then those over age 62. In both cases, they increased, and I'm sure if we did the survey again, we would find that it continues to increase. We also do vulnerability surveys in our community, as many communities do. And you see in 2013, of the 111 most vulnerable individuals experiencing homelessness, the median age was 49, and 33 of them were between the ages of 52 and 61. So this just reiterates the point other presenters made. This is a real and urgent issue. We did host a convening. We had 13 attendees from both homeless services and older adult service nonprofits. We had a productive discussion, but unfortunately we haven't had any follow-up from that point, and it is something that I think we would need to reconvene and have a specific action plan, probably need somebody focused on this particular issue. Next slide.
Next slide, please. So in presentations that I've done both at the American Society of Aging in America annual conference and at Grantmakers and Aging's annual conference and in other places, we've essentially talked about three populations of older adults who are homeless who are either homeless or who are very nearly in danger of homelessness that we've noticed out in the world. First, the chronically homeless, and Nancy did a great job addressing the needs of that particular population, what's happening in that population. Peggy, rather, sorry. Nancy, you did a great job talking about what, in effect, are the new homeless, which are those older adults who become homeless as a result of the collapse of their support structures, which are essentially financial supports, service delivery supports, and how to engage folks in those particular areas. And we are particularly concerned about the third group, which are the vulnerable and housed. So it's those folks who have housing, and Nancy talked about this a little bit, those folks who are already housed, but because of collapsing support structures in permanent supportive housing, or the inability of permanent supportive housing providers to deal with the complexity of issues facing older homeless individuals, become homeless in the course of time.
Or I wanted to give a specific example here, because what happens is there may be a grantee, or there are grantees within the homelessness portfolio who I work with, for example, a local group called Women's Housing Coalition, who expresses difficulty serving its aging population. Now, this is an opportunity for us internally to, talk about what could be done about this. How do we connect this grantee to grantees within our older adult services? And this is where these discussions emerge. And I really do see our local grantees grappling with this question.
Right. Next slide, if you will. So we want to bring up this whole question of elder abuse and homelessness. The Weinberg Foundation, among the things we fund, has increasingly focused on interventions in elder abuse, and one of the areas that we've focused on are elder abuse shelters. There are about 13 of these in the country right now, and we're gaining a great deal of information regarding what happens to people in regard to elder abuse. About 4 in 10 older adults experience elder abuse during their lives. At any given time, somewhere between 5 and 10% of all older adults are experiencing elder abuse. Most elder abuse is financial abuse, and of course, financial abuse often has a direct relationship to homelessness. We don't know a whole lot about the relationship between elder abuse and homelessness, except that most people who are working in the field believe that there is a connection between them. And obviously, as I just said, some of that has to do with financial exploitation, but much of it also has to do with physical abuse, which causes hospitalization, and in the process, as Nancy alluded to, people can lose their homes, they can lose their income. Many older adults, people over the age of 62 or 65, are in the workforce and become abused. You lose your job because you don't show up, and then you lose your home. People lose their homes as a result of living arrangements gone awry, evictions because the abuser has control over money, takes it away, person is unable to pay rent or mortgage. Landlords or fellow tenants subject to the fighting and the noise, drug dealing that sometimes goes on in the apartments of people who are abused and lose their homes. Or trauma, which is the result of people fleeing their homes to avoid abuse, end up going to an emergency room because that's the only place they actually feel safe. I once had the administrator of Mount Sinai Hospital in Chicago, which you probably know, Peggy, which is one of the largest emergency rooms in the city, say that she was really running an elder abuse shelter while she was there, noticing who was there. So,
next slide.
Next slide, please.
So I think Peggy did a really great job outlining the issues to consider. This is a snapshot of some of the things we see ahead. One is to strengthen homelessness prevention for the precariously housed older adults, and an example of that is the National Council on Aging Economic Stability Centers, which assist people who are having financial challenges, may not be able to pay their mortgage, need help with benefits. All of these things are important for any population to remain housed. And then this training for permanent supportive housing providers on caring for older adults and aging residents. Does that mean bringing in other services? Does that mean referrals? And then the next point is when those referrals happen, long-term care providers aren't necessarily equipped to provide services to folks who have come out of homelessness, perhaps into housing or not even into housing. So I think there is a lot of training, and we expect to see more requests along these lines in the future. And then, we all know that there's a continued need to develop affordable housing with services that's appropriate for this population.
One last word before we move on to our final slide and goodbye from our presentation is we at the Weinberg Foundation have decided to create what we call Making Maryland the Best Place to Grow Old. Making Maryland the Best Place to Grow Old, which we hope to do by 2020. And part of that is to draw in the great lessons that we've learned from all the funding that we've done around the country, including San Diego and Chicago, and the things we've learned from our national family family and informal caregiver initiative, which we did in 14 sites in 9 states between 2009 2012. We will continue to fund around the country, but as many of the people we're funding now outside Maryland and Northeast Pennsylvania know, we ask you to have a partner here in Maryland and Northeast Pennsylvania so we can learn. So last slide.
Questions.
And so you have our contact information, and we're happy and eager for questions, John and Steve.
Thank you very much. Thank you to all of our presenters, and we will turn to our questions now that you addressed. This is for all of our presenters, but I'll start with Peggy on this one and then move to Nancy. We're in a phase of time when the Affordable Care Act and other legislation is causing hospitals and other long-term care providers, both institutional and particularly in the community, to try to work together in a different way, to coordinate their activities in a different way. Could you tell us what you're finding about that in terms of providing homeless services? And I think the question that I'll have specifically for Nancy is, are you able to capture some of the savings that the hospitals are experiencing and in some way use that to provide better services in the community? So Peggy, let's start with you on that question.
Okay, great. So yes, so we're definitely seeing hospitals begin to experiment with how to do this because, as the question said, within the ACA, and particularly on the Medicare side, hospitals are getting penalized if they have readmission rates that are too high for folks. So they're trying to figure out how to address that, with also keeping in mind, though, that hospitals get paid. We haven't made that grand transition from getting paid by fee-for-service or by the number of people or the amount of things you deliver and getting paid for outcomes. So hospitals are to be on their side they're caught in this catch-22 where they're getting penalized for utilization, but their revenue stream is based on utilization, and that has been interesting. So what hospitals are doing is trying to think about how to use their community support benefits that they have for this population and homeless populations in general. So that's one thing that I would say is that hospitals are using that and the benefits that can be gained and what they can gain by using their community support benefit by thinking about how to target it to homeless population. So, for example, in Orlando, Florida Hospital System, we're working with them to, they've made an investment into a pool of funds the city, county, and philanthropic organizations have put together to develop supportive housing for high-cost members. And the point of putting it in that pool is so that that hospital can then reach out to the resources that are in the community and help build capacity.
Well, Nancy, let's turn to you with that same question. Have you seen this same kind of activity in San Diego, and are these organizations working together to somehow, make sure that the money flows around to follow the clients, or is that still a struggle?
I think that there's still some struggle there, and what I see in our community is I wrote these down in terms of competing priorities. The cultures are very different between the different service providers, between the hospitals and the different service providers, and then you get into all of the details of making any collaboration or any real work like that actually happen, and it's a really slow process, and especially when you have the competing priorities and the priorities that are going to take away a lot of their attention. And I think I sometimes sit here from the funder's perspective and wonder really how much the health systems can actually absorb when everybody's talking about the savings that they're creating for them. When savings actually don't show up in the bottom line of any hospital setting, because if you're really creating capacity through the changes that you're making in the system by not having people come into the hospital setting, they're going to fill those beds with the other because we don't have 100%. We have unmet needs still in our community, is what I'm trying to say. So I think that there are opportunities to look at how we are creating savings for the health systems. It has to be proven, which takes time. And I also think that we really have to look at what, like Peggy was saying, really looking at the difference of how what we're paying for and how we're paying for it to really make a difference in our system.
Well, Michael and Amy, let's turn to you with another question from a locally based funder saying, do you have some good examples of what local funders can do around these issues? Obviously not able to dedicate huge resources to this, but what are some of the most useful things that local funders can do?
First, we'd like to ask Steve, can you advance the slide so people know how to get in touch with us?
I don't have it there.
We're on the last slide.
We're on the last slide. Okay. So, sorry. So I think some of these are really important that we've already done. Two of the projects we talked about are construction, actually three of them, but there are a couple of ideas we have. For example, the Making Maryland project initiative that I mentioned before is really based on supporting the creation of networks between service providers to actually talk to each other, create the kinds of linkages, pay for care managers so you have one group of folks talking to another group of folks. Do the kind of work that DeRote has been doing, support the kind of work that DeRote's doing in New York, which actually trains people to work with individual older adults to help them figure out how to best connect with systems, with various networks that might actually be out there. A lot of this isn't terribly expensive.
Another suggestion, most communities have a local plan to end homelessness. Ours is called Journey Home, and there is a coordinator supported by philanthropy of that effort. And if you were really interested in this particular issue, you could hire someone who would do this coordination, would do the convening, would dig into the issues. So if you're able to do that, I think that'd be a great, modest investment that would have returns.
I also want to talk for 1 second about the leverage of local funders. Most not-for-profit hospitals get some of their funding from local funders for some specific area. The next time a local funder gets asked for money for some specific area of work by a local hospital, it'd be really important to raise the issue. Say, what are you doing for homeless older adults or older adults who are in danger of homelessness? That's leverage. Many foundations have a lot more leverage than just the money, just the checks that they happen to write.
John, could I add, this is Peggy, could I add one thing that we've seen two local funders do?
Sure.
Many people may know CSH is involved in this, experiment of thinking about pay-for-success models or social impact bond investment in ways that where philanthropy is getting involved and being an upfront investor in projects that they expect will meet certain outcomes and save usually government's money. So because to get at what Nancy was talking about with cost savings, what we've been doing is going to a governmental level of either the city, the county, or the state who sees all the pieces of the budget, the pieces that are going to go up and the pieces that are going to go down, so that hopefully in total things will be decreasing. And local funders have been exploring this idea in communities and states about, okay, is there a way for me to provide an upfront investment in what you're doing and set very specific measurable outcomes and cost savings projections to house populations. And the senior population is one of those that if we can keep them out of institutional care or those that are cycling in and out of nursing homes in the street, if we can keep them housed, we could save enough money that a pay-for-success type model might work.
Well, thank you very much. Unfortunately, that's about all the time we have for questions today. I want to turn now to our panelists and ask them for their final words of wisdom to our audience. And Peggy, we'll start with you.
Great. So I guess my final word of wisdom is that this is an important population to focus on, and as I think you could see, there are different aspects of each within the population that need priority, and what programs struggle with that Nancy talked about is this is how to have the right staff at an increased intensity level to make all the outside connections happen, because it's hard to make these partnerships happen, and it requires some intentional focus of the programs and the governmental and community entities that are trying to make it happen.
Nancy?
Thank you. I'd say two things, and actually I wrote down that I would really encourage funders to continue to take risks and to push the envelope and to really push our communities to think differently and bigger and more innovatively. But I also would say to the person that asked the question about being local, I think in some ways that's easier to get much more involved in the in-depth kind of issues that are happening in your community, and encourage you to do that as well, because that's where the ideas really come from.
Michael and Amy.
So we want to remind people that all older adults are important populations to pay attention to. That one of the sobering facts in this field is only 1% of all foundation dollars go to support programs and services that support older adults. Having said that, it's what happens to the most vulnerable older adults that really drives how we make decisions and how the population will look in the future. And it really is up to local decision makers about how these populations are treated. Thanks a lot, John. Thanks, Steve.
Thank you.
Thanks, Anita. Thanks, Peggy. Thanks, Nancy.
Amy, any final words from you?
I'm excited to bring these two fields together. I think there are a lot of opportunities to leverage. I can't add more to what Michael said, but thanks for the opportunity to highlight this issue.
Well, I want to thank Peggy Bailey, the Director of Health Systems Integration at the Corporation for Supportive Housing, Nancy Sasaki, the Executive Director from the Alliance Healthcare Foundation, Michael Marcus, Program Director, Older Adult Services, and Amy Kleine, Program Director for Basic Human Needs and Health, both at the Harry and Jeanette Weinberg Foundation. We thank you all for all that you do to make life better for older persons. I also want to thank the John A. Hartford Foundation for their support of this program and the American Society on Aging for their technical expertise. We'll be providing this presentation to everyone who wishes to view it later, so just look at our website or send us a note at info@giaging.org or watch the announcement that you received about this program before. And watch our GIA website for future webinars. This is a free series for everyone involved in the aging field. And finally, I want to thank all of you for the great work that you do and for participating in today's webinar. Have a great day.